This patient is a 63-year-old male who admitted to our hospital with a chief complaint of the paroxysmal chest pain for 3 months. His risk factors include hypertension, myocardial infarction, smoking, and alcohol drinking history. The echo check in our hospital shown the injection fraction value is 63% and the cardiac structure is normal. This is an essential ECG result. It is shown thinner rhythm with VPC, and the patient was suffered from acute myocardial infarction 3 months ago and received PCI at a local hospital. This is a previous angiography image. We can see the calcified lesion in left main and 80% stenosis in proximal to the middle LAD, with LAD fourth diagonal branch is a true bifurcation lesion and relative normal LCX, with 60% stenosis in OM and 17 stenosis in proximal to middle RCA, with severe calcification after standard deployment in LAD. Unsignificant slow flow was occurred, and the procedure had to be stopped due to the unstable hemodynamics. Patient is now planned for complex IVUS and or OCT guided PCI of left main to LAD using RA and or shockwave IVL, and we will analyze the characteristics of the proximal lesion and evaluated the LAD stand expansion by the intravascular imaging. Considering the angina symptoms, we calculated the QFR, a novel non-invasive physiology assessment method invented by Chinese scientists, and the LAD is 0.58 and RCA is 0.93. So we could know the LAD cause physiology echythmia and could be treated. As we know, although they had some disadvantage of FFR, such as the pressure wear is difficult to manage, relative long learning curve, and limited by medicine for some patients. It is still the gold standard for physiology financial assessment. Just now, we had finished the FFR check. FFR for LAD is 0.59 and FFR for LCX is 0.95. So we can see the FFR is very close to the QFR value. We can see the proximal LAD image is his, and it is difficult to evaluate the plaque feature. Even the image had been magnification. In this situation, we are impossible to make a detailed PCI plan before the procedure.
Now you can see the intelligent visualization system for coronary CT angiography, which is original invented by Professor Li Yue, just like the system we showed in the former cases. We can see the reconstructive view of aorta, coronary arteries, and their plaques. We can focus on the left coronary artery now. There is also severe stenosis in the proximal LAD, and we can see that the severe calcification is in the proximal LAD and also in the ostium of the LCX. We can see there's almost 360-degree calcification.
We can see at the end of the left main a significant calcification, nearly 80% to 90% stenosis in the medial LAD to the proximal LAD, nearly 70% stenosis, and severe calcification in the medial RCA to the proximal RCA, nearly 50% stenosis in the proximal LCS.
I think we got a very complex case. It's a left mean bifurcation lesion with a lot of calcification, and the circumflex looks kind of normal from the angiography. And there's mild to moderate stenosis in RSA, but the functional assessment was negative. But this patient was stented before in the middle of RD. So right now, based on the patient's information, what's your initial strategy? Yeah, for this kind of lesion, the imaging test is super important. But both IVUS and OCT, they have their pros and cons. But right now we have integrated imaging system. I think this is a genius idea. It was invented by Chinese company. So with this system, we can make full use of their strength and countering their limitations.
Here, after identify the reference vessel segment, we had access the MSA in LAD is 5.11 square millimeter hours. Distal less than 2 millimeter distance had no over 16-degree dissection. So we know the previous stent not got the previous stent had got the optimization results. Accompanying with the catheter backwards, we calculated the MO in LAD as 2.09 square millimeter. As we seen, we can see the cross-section view. There had a calcium field lesion over 118 degree from 2 to 9 o'clock. So I think the osteo LAD may be not an ideal stent location. As we see, the FFR for LCX is 0.95. In summary, I think gel wire technique is a rational choice for the LCX protection. And as Professor Gong said, we will use crossover technique to treat the LM-LAD lesion. According to the definition criteria proposed by Professor Chen Shaoliang in China, we know the lesion in side branch is longer. This patient LCX lesion is longer than 10 millimeter, but the stenosis diameter is less than 70%. So we think this is a simple bifurcation lesion, and it depends on the results of definition theories trials. The provisional stent strategy is rational.
So right now, Dr. Gong is trying to pass the IVL catheter through the lesion.
Now we use a 3.5 IVL balloon to pre-treat the calcification lesion.
So now you give the pressure to 4?
Yes, 4 ATM, and then we are inflated to 6 ATM.
So after maybe 10 seconds, we increase the pressure to 6.
Yes.
Sometimes, when we try to use IVL to correct the calcification, we have to do it a few times, right? It's not just a one-time thing. For the treatments of calcification, except for IVL, maybe there's some other techniques like rotational atherectomy or some dedicated balloons. So for this patient, you prefer to use IVL. So I think after the IVL, we have to run the imaging test, right, to see the results.
So as the IVI shown, there is some superficial and some deep calcium field lesion in LED. We choose the IVL shockwave balloon to modify the LED calcium field lesion. So IVL has been recently introduced as a novel technique with potential to safely modify calcium field and optimize stent expansion. So this pressure wave are able to selectively break both superficial and deep calcium within the vessel wall, backbreaking macro fractures in the calcium field plaque. Vessel compliance is increased, and IVL thereby facilitate adequate balloon and stent expansion. So vessel trauma is soft tissue is minimized as the sonic pressure wave pass through non-calcified tissue as a result of minimal differences in density.
Yeah, compare with the RA, the IVL is very safe, and the risk of the no flow is very, very low.
Oh, of course, inherent to its concept, calcium fragments remain in still after IVL treatment, so potentially reducing the occurrence of slow flow or no reflow. Yes, the balloon is inflated at pressure of 4 atm initially, and then impulse of mechanical energy delivered to the calcified lesion at a frequency of 1 Hz. So this energy interacts with the atherosclerotic plaque, cause vibration that cracks and fractures the calcified columns in the superficial and the deeper layers.
So now we finished the IVL, right?
Yes, and we will recheck the intravascular imaging to evaluate the results of our pre-treatment.
The best advantages of this integrated system is it can complete each other disadvantages.
Yeah, 2 images, IVUS and OCT.
In one screen.
Fantastic.
Yes, we can see the imaging quality as well. Here we can see from the 9 to 12 o'clock, there has some cracks of the calcium film lesion. In addition, more importantly, the previous some under expansion stent have been improved significantly.
Dr. Gong, do you think right now the result is okay, or with no need for more IVL? We just maybe treat it again with some balloons, right?
Yes, we will modify the leading further using NC balloon and the 3.0 NC balloon to get further modification for the calcification leading. And then we will deploy full stent next.
So we have to try our best to make the lumen as big as possible. And they'll be very easy to deliver stents.
And now Professor Gong has used a NC balloon to treat it.
I think the balloon can be very easily expanded. That means the IVL really worked.
So for this case, there had a significant discrepancy aside between the left main and the proximal LAD. So in this situation, we often choose the stent size depends on a set branch that cause inevitable mismatch. We often dilated the proximal stent by NC balloon 1-to-1 ratio with the proximal main vessel size. So with our experience, Professor Gong is preferred to choose to consider region of the inherent feature of the different stent platform, such as the chrome numbers, cell area, and choose a stent which has the best expansibility to deployment in the proximal LAD to left main.
Okay, very.
So after the pre-treatment, the result is okay. So right now is the time to put the stents, right?
Yes. And according to the intravascular imaging result, the first stent we will choose one 3.5 diameter.
Because the septal branch is kind of big. That's why we had to protect it before we put the first stent. But for this patient, the septal branch is kind of big. That's why Dr. Gong, put a balloon to protect it.
Of course, yes. So for the left main lesion, bifurcation left main lesion, the rule number 1 of the PCI is to identify whether is it a true bifurcation lesion. According to the Medina classification, this patient is according to a Medina 011 subtype. The FFR value showing us the LCX is 0.95, and another factors another reason is the IVL image. We also see the ostium area of LCX and the black burden both tell us just through a gelled balloon technique is enough to protect it.
So Dr. Gong, the first stent could be well expanded?
Yes, And the next stent will deploy
So what's the size of the second stent?
4.0.
Because the second stance will be extended to the left mean, so
Yes.
it should be big. So I think the second stent was also well expanded, right, Dr. Gong?
Yeah. Next step, we'll recheck the intravascular imaging and to evaluate the stent expansion and if
The port NC balloon size is should be very short. The size is selected by the barrier stent size.
Maybe have some distance from the struts, center struts between the left main vessel wall. So we need a AC balloon to post dilated the left main stent.
Yeah, there's a little bit malposition. I think, from the IVUS image, it's more clear than
Full
OCT,
file
right?
NC
You could
balloon.
see the malposition.
The MSA in the left main is 80.78 square millimeter. It's very large.
okay, after perform the pulse technique, next step we'll revise the circumflex and then to perform heating balloon technique.
So this procedure is necessary after POTS. You do this routinely in your practice. So what do you think of this question, Dr. Zhao? After the POTS, do we have to do the KBI routinely, or it really depends on the situation?
KBI involves the inflation of two non-competent balloons. One is in the main branch, just like LAD, and the other is in the sand branch, LCS, whose proximal parts are lined in the proximal main branch, just like in the left main. The aim out of the procedure after LM to the LAD standing is to remove the stent struts at the sand branch, just like LCX outterm, to eliminate the stenosis of the sand branch and maintain cranial in its central position.
Yeah, you know what? For this patient, I think the pod is super important because after the pod, I think it's kind of easy to deliver a wear through the ostium of the circumflex.
Dr. Gong just tried to deliver the AC balloon to the LCX distal, but it's hard to across the stent cell. So he firstly use a relative smaller NC balloon to the LED proximal, and he will post dilate the NC balloon at first, and then try to deliver the NC balloon to the LCX distal. That would significantly enhancement of the pushability of the NC balloon.
So first we use a small balloon to dilate the strut cell. And then after that, if the strut cell is large enough, we can deliver the balloon we want.
Yes.
Because right now, Dr. Gung is trying to dilate, all the parts of the stents in the LED. Maybe he wants to have a better results.
Yes.
Next, we will choose the 4.0 and the 2.5 AC balloon to perform AC balloon technique. Yeah.
The balloons are engaged already.
Okay.
2.5 in the circumflex.
Yes.
4.0 in the left mean. When we do the KBI, we cannot give the pressure too high, right?
Yes. Even a lower pressure with about 8 to 12 ATM.
Just to make sure the stents can be well expanded and it doesn't cause any other complications.
Yeah.
That'd be good enough.
For this patient, we can use a modified kissing balloon technique.
So tell us more about that.
The sand branch NC balloon should be inflated firstly, and then deflated to 4 ATM, and then in the main branch, the ANC balloon should be inflated with a short overlap and deflated immediately. Now we just complete the KBT, that is kissing balloon technique. Okay, we will recheck the intravascular image to get the optimal stent deployment. We will show a final angiography. It's very excellent.
Yeah, from the angel, it looks very good.
Yeah. Next step, we will perform a report to modify the position of the stent in the left man.
So sometimes, for the left mean bifurcation lesion, after the first pulse and the KBI, and if the result is not very good, we have to do the port again, right?
Yes. A report after kissing balloon inflation. A report is also necessary for the bifurcation lesion, especially the left main bifurcation.
It's my great honor to perform 2 live coronary intervention cases from our center, Nanjing First Hospital, via a medical team.